Good morning, everyone. Welcome to day 2 of the PACCARB meeting. This is the 21st public meeting of PACCARB. My name is Martin Blazer. I serve as the chair of the council. We'll begin just with a very brief wrap-up of yesterday. And my briefest of all wrap-ups is that I was really impressed by all the innovation I heard about in terms of both tools and methodologies, as well as the continued commitment to working on AMR after our, let's say, 2-year COVID hiatus. Now let me turn it over to Dr. Apley for some more remarks. Dr. Michael Apley is the co-chair of PACCARB.
Thank you, Dr. Blazer. I think we all probably had some takeaways from yesterday. I know I took away a lot, and also from the round robin, there were a few really key points that struck me yesterday that I wrote down. One was Dr. Fernandez, who pointed out something that came up a lot of times during the day, that any pandemic requires effective and available treatments for primary and secondary infections. I think something we'd all agree on. Dr. Whitaker pointed out that context matters and that social, cultural, and political conditions impact the evolution of host-associated microbes, infectious disease emergence and control, keeping us in the context, of what we're talking about. One of the big points I took home also was that we can't continue to move crisis to crisis with periods of minimal attention and resource allocation in between, that we have to keep the attention up. The analogy of peacetime and wartime was used, where during the downtime in between, we have to prepare for what we know is coming next. Another one was the perception of risk can both drive and hinder adoption of AMR monitoring and reporting. So risk can go both ways, and we have to carefully manage that, both the actual risk and the perception of it. The other one was, of course, Dr. Chiller's talk brought us back to the fact that fungi very much matter, and that antifungal susceptibility testing, we need to continue to put an emphasis on that to give us that capability. In talking about AST, I think Dr. Main's presentation and others about diagnostics brought to the forefront that we have an issue with antimicrobial susceptibility testing with today's technology of scalability, both in materials, throughput, and people to put those samples through. We need to continue and focus on continuous AST improvement. And then lastly, I think one of the takeaways was we have some surveillance programs going on right now that are funded with COVID funds, such as our wastewater and expanding, the National Hospital Safety Network to long-term care facilities, that if we just allow that to go off with that funding, then we lose 2 valuable programs that we need to focus on. How do we keep those going? And that goes back to a central theme of, having, come this far through COVID, we can't let that intensity come down. We need to keep that intensity in looking at AMR. So, Dr. Blazer, thank you.
Great. Well, with those comments, let's turn over the podium to Dr. Joanna Musmar, the designated federal official of PACCARB.
Thank you, Dr. Blazers and Apley, and welcome back, everybody, to day 2 of our 21st public meeting. Yesterday was an action-packed full day, and hopefully today will be the same as we look at the response component of our MARC scenario. Today we're going to explore infection prevention and control as we continue to hear from a variety of experts and discuss the continuation and the progression of this MARC scenario. Again, the scenario is only an exercise and does not represent real events. But before we begin, a reminder to everyone that this meeting is being recorded and it is also being streamed live at HHS.gov. Second, our live verbal innovation spotlight with pre-registered companies will be provided this afternoon. Third, once again, the Advisory Council is governed by the Federal Advisory Committee Act, or FACA, and as such has rules about the circumstances by which agencies or officers of the federal government can establish or control committees or groups to obtain advice or recommendations where one or more members of the group are not federal employees. The majority of the work of this advisory council, including information gathering, drafting of reports, and the development of recommendations, is performed by designated working groups who in turn report to the full council for deliberation and final vote, as reflected in our pandemic preparedness working group, led by Drs. Ramanan Lakshminarayan and Joni Sheftel. Regarding the conflict of interest rules, All 15 voting members of the council are considered special government employees or SGEs and are subject to conflict of interest laws and regulations. The 12 regular government employees or RGEs representing different agencies and departments on the council have also been vetted for any conflicts of interest. They've all received and reviewed information regarding the standards of ethical conduct for employees of the executive branch. On the other hand, the representatives from various organizations are non-voting members of the Advisory Council and are not subject to the same FACA rules as the SGEs or RGE members. I'll now go through a roll call for council members. Please let us know if you're present by stating here. For alternate representative members, please identify yourself and provide the name of the principal you are representing today. All right, starting with our voting members, our chair, Dr. Marty Blazer.
Here.
Our vice chair, Dr. Mike Apley.
Here.
Dr. Stephanie Black. Here. Dr. Helen Boucher, I know could not be with us, and I believe she's joining via live stream. Dr. Virginia Fate. Here. Dr. Paula Cray is not here. Dr. Christine Ginocchio. Here. Dr. Locke Carricker couldn't join us. Dr. Elaine Larson. Here. Dr. Ramanan Lakshmanarian.
Here.
Mr. Armando Nehum.
Here.
Dr. Payal Patel. Here. Dr. Paul Plummer.
Here.
Dr. Julie Shimzak. Here. Dr. David White.
Here.
Moving on to our liaisons. Carla Houston for the American Association of Extension Veterinarians. Here. Dr. Joni Sheftel for the American Veterinary Medical Association. Here. Ms. Emily Wheeler for the Biotechnology Innovation Organization. Here. Dr. Lisa Marigakis for the Healthcare Infection Control Practices Advisory Committee, and I know she's joining us via live stream. Dr. James Adaskovich for Minor Crop Farmer Alliance, also via live stream. Dr. Jason Newland for the Pediatric Infectious Diseases Society. Here. Dr. Libby Dodds-Ashley for the Society of Infectious Disease Pharmacists. Here. And lastly, Dr. Timothy Jinks for the Wellcome Trust.
Here.
All right, on to our regular government employees. For USDA, Dr. Jeff Silverstein. I believe Dr. Roxanne Montroni is on live for Dr. Silverstein. Dr. Sarah Tomlinson.
Chelsea Shively here for Dr. Sarah Tomlinson.
Thank you. Dr. Emilia Esteban.
Nina Anandaraman for Dr. Esteban.
Fantastic. For the Department of Defense, Dr. Paige Waterman.
Here.
For HHS now, Dr. Melissa Miller, HRQ.
Here.
For CDC, Mr. Michael Craig.
Here. Here.
For CMS, Dr. Sherry Ling.
Jasmine Gunza in lieu of Dr. Sherry Ling.
Thank you, Jasmine. For NIH, Dr. Dennis Dixon.
Kyungmoon here for Dr. Dennis Dixon.
Thank you, Kong. For OGA, Dr. Lynn Philby.
Here.
Excellent. Moving on to ASPR, BARDA, Dr. Chris Halgens.
Here.
FDA, Dr. Bill Flynn.
Here.
And I know that Dr. Rapeshawad is also joining us via live stream. And lastly, with EPA, Dr. Jay Garland could not join us, but I believe is also via live stream. Again, thank you all for attending this important meeting. Just a few housekeeping items to remember. When asking a question, please hold everything until the very end of the panel. Make sure you turn your microphone on and off so that our folks in virtual world can hear you. And make sure that you turn the placard sideways and we'll pick up on your questions. I think we did a good job of that yesterday. Hopefully we'll continue that today. I now pass it over to our chairs. Or wait, hold on. Breaking news. Wait, is it breaking news or not? No, first we go to our chairs. I'm sorry. Wait, there is a news update. I'm sorry, folks. We have an update. I'm just getting it now.
This influenza pandemic has been unique in the sheer burden it has placed on both the U.S. healthcare system and food supply chain. Case counts and hospitalization rates due to the ongoing influenza pandemic continue to climb. As of today, there are now 250,000 new cases daily, with 120,000 hospitalizations nationally. At this point, most hospitals are inundated with patients and are running out of space. Hospitalized patients spend days to weeks in the hospital, which is further worsening bed shortages and healthcare burnout, and as a result, the rates of hospital-acquired infections are skyrocketing, further frustrating an already dire situation. While the pandemic is spreading through the U.S. population, it is also ravaging the U.S. pork supply chain. The U.S. swine population has been decimated by the influenza virus, and associated high rates of secondary infections. The nation is looking to the administration for leadership and science-based guidance to address this public health emergency.
Good.
Hello, everyone. Ramanan and I would like to welcome you back today. Just a reminder, a recap, that this meeting is a policy workshop looking at how antimicrobial stewardship and AMR prevention can and must be incorporated into pandemic planning and response. Our main objectives will be to identify gaps in existing pandemic preparedness and response guidance, and then to determine what federal actions and policy changes are needed to make this happen. Yesterday, we talked about peacetime and wartime. This meeting is about wartime, which raises the ante because of a shorter timeline for decision-making and more compelling conflicting priorities than in peacetime. All of us can recognize that the problems we deal with today are more complicated, more tangled, and more often occur at the interface of human health, animal health, and environmental health than even 10 or 20 years ago. That is why we take a One Health approach. It's not about being nice. It's our only hope for managing problems like these. The discussion today will be centered around two major topics or modules: vaccines and therapeutics, and infection prevention and control and biosecurity. Each module will include a panel of experts from both human and animal health. After the presentations, there'll be an hour-long discussion session. Thank you, everyone. Oh, wait, apologies. We are interrupting these proceedings for some breaking news from PACCARB. No, there's another one.
As the influenza pandemic continues, the federal government is exploring multiple avenues to encourage the expedited development and production of new treatments for the secondary bacterial and fungal infections that have been driving the high number of deaths. To mitigate the large number of hospital-acquired infections, a new influenza vaccine is being developed to hopefully reduce the number of severe illnesses and hospitalizations. Federal agencies are also researching new therapies and vaccines for the pork industry to mitigate the large number of resistant infections within their swine herds. Experts hope that the lessons learned from the distribution of COVID-19 vaccines can be leveraged to efficiently and equitably distribute the new therapies to all communities.
In this first module on vaccines and therapeutics, we will explore how to close gaps in development, production, and use of medical countermeasures to reduce the impacts of an AMR pandemic within a viral pandemic. What will be needed to prevent and treat infections, and how do we quickly meet those needs? How do we ensure availability and access to antimicrobials and vaccines? How do we develop new products and tap into existing pipelines? How do we provide needed clinical guidance for those new products and indications, and communicate with our human and veterinary practitioners about them in real time? We have really got a wonderful panel today. I'm looking forward to hearing from all of them. We have Dr. Kyung Moon from the National Institute of Allergy and Infectious Diseases, Dr. Mark Albrecht from the Biomedical Advanced Research and Development Authority, or BARDA, within the Administration for Strategic Preparedness and Response, or ASPR, Dr. Michael Roof from Iowa State University, Dr. Emily Spivak from the University of Utah, and Dr. Gail Golab from the American Veterinary Medical Association. Dr. Kyung, Moon, would you start, please?
Thank you. First of all, I'd like to thank the organizers for inviting me. Today, I will talk about potential NIH strategies for developing vaccines and therapeutics in a public health emergency such as the past pandemic. Next slide. Okay, so NIH is the largest funder of biomedical research in the world. of 27 institutes and centers. NIAID is the lead institute for AMR research. Next slide. NIAID has a dual mandate to pursue a robust research portfolio and to launch a rapid research response to newly emerging and re-emerging infectious diseases. Thank you. Next slide. AMR posed a major global threat to human health prior to and during the COVID-19 pandemic. According to the Lancet paper, the AMR impact across the globe was deadlier than we thought. In 2019, the death toll due to AMR infections reached over 1 million. This is nearly equal to those from HIV and malaria combined. In addition, escape pathogens, including gram-negative bacteria, are among the top 10 agents for AMR deaths. In July, CDC also published a special report indicating that there was a 15% increase in AMR infections and deaths among hospitalized patients in 2020 compared to 2019. This increase is apparent among known AMR pathogens, including escape. Next slide. In response, we are putting special effort into investigating non-traditional approaches, including vaccines, which will also help with the best pandemic for the following reasons. Firstly, we have limited drug to treat the AMR pathogens because they've developed resistance against the last resort antibiotics. Secondly, it's difficult to develop antibiotics for gram-negative bacteria due to their physiological characteristics. Also, vulnerable populations at ICUs and nursing homes are burdened by AMR infections, where conventional treatments are limited. Therefore, we've increased R&D for alternatives, such as with bacteriophage, microbiome-based therapeutics, and vaccines. Next slide. Especially vaccines have proven effective in reducing the incidence of AMR in certain pathogens. There are indirect and direct benefits of this promising approach. Indirect benefits may be seen in preventing respiratory viral infections. For example, influenza vaccines prevent or reduce flu, but they also reduce unnecessary use of antibiotics for secondary pneumonia. An example of direct benefits is shown in the prevention of pneumococcal pneumonia. This also reduces antibiotic use. Nevertheless, there are global challenges. The uptake isn't robust in high-income countries, and in low and middle-income countries, these vaccines are not widely available. Lastly, developing target vaccines for escape pathogens isn't easy due to their antigenic variations among clinical isolates. Next slide. Despite these challenges, for over more than a decade, we've promoted various programs for traditional and non-traditional approaches by funding basic, translational, and clinical research. And I highlight a few programs throughout the next couple of slides. Next slide. Basic research aims to understand AMR in bacteria as well as identify ways to combat it. This type of research is supported by both investigator-initiated and targeted initiatives. A couple of examples are modeling the host pathogen molecular networks and understanding the mechanisms of phage biology. Next slide. Translational research aims to advance novel findings into products for AMR. 3 major programs support this type of research. Firstly, as seen in the far left on this slide, various grants and product development contracts support US-based and global research. Some examples are developing vaccine candidates and making large-scale phage prep. We also offer structural biology, genomic, and bioinformatics services and access to BI resources to develop next-generation vaccines and therapeutics. PCS includes in vitro screening assays and animal models, as well as comprehensive tools to support applications of new drugs. This is available free of charge to eligible scientists. Next slide. We support several clinical trial networks to evaluate new products. These include the phase 1 clinical trial units to monitor the safety of therapeutic products. For example, the network conducted a safety study of CRS 3123. The IDCRC evaluates vaccine and therapeutic candidates. An example is the Vaxero study to assess mucosal immunity post-vaccination for gonococcal infection. Finally, the ARLG, launched in 2013 and renewed in 2019 for 7 years, is currently conducting a phase clinical trial to treat Pseudomonas aeruginosa infections in cystic fibrosis patients. Next slide. So our multi-layered approach has maintained high-quality research and has facilitated the translation of basic research findings into new products. Also, we've provided a flexible infrastructure to respond to the current pandemic. A few things that we've learned from the current COVID-19 pandemic are: prior scientific advances enable therapeutic and vaccine development. For instance, we couldn't have developed our current SARS-CoV-2 mRNA vaccine without continuous ongoing research. Developing product is a lengthy process, even though we have potential candidates for vaccines. Although we have potential products, mobilizing clinical trials in a timely manner is necessary in order to apply for FDA approval. Expediting regulatory processes was needed to provide the therapeutics and vaccines to the public quickly. In addition, we encountered unexpected global shortages in the supply chain. From these lessons, we recommend preparing for the base pandemic as follows. We need sustained research for priming the therapeutic and vaccine development pipeline, and continued screening of high probability compounds and vaccine candidates. We also need to repurpose existing therapeutics to shorten the time it takes to reach the final stages of development. We need to leverage existing clinical trial networks to conduct rapid research on new products and to expedite their availability to the public. Finally, we need collaboration with other federal and global partners to mitigate any unseen regulatory hurdles or to eliminate bottlenecks in the global supply chain. Next slide. Thank you for your attention.
Thank you, Dr. Moon. That was fascinating. Next, we have Dr. Mark Albrecht.
Good morning, everyone, and thank you again for the opportunity to come and present to you and talk to you a little bit about how the Administration for Strategic Preparedness and Response takes the products that NIAID has worked on and the NIH has developed and bring those products forward to the patients, and ultimately, as a part of our mission, procure those products and distribute them during a public health emergency. Next slide. So ASPR's main priority role is to lead our nation's public health preparedness and emergency response. This really is engaging all agencies across the federal government, as well as state and local governments, ensuring that there is coordination during that public health response, but also ensuring that we are prepared prior to that response. Now, we have several key priorities right now. Clearly, responding quickly during the COVID pandemic is a key priority for us, and ultimately extending our capabilities in the areas of logistics, public health, medical surge operations, medical countermeasure development, as well as the distribution of those medical countermeasures. We also are prioritizing the restoration of resources and capabilities that have been diminished during the COVID-19 response. In particular, I'm talking about the Strategic National Stockpile, as well as securing the public supply chain of products. Finally, we are preparing for future events. One of the key priorities of ASPR is to always be looking over the horizon to identify what is the next threat that is coming down the way, and how can we better prepare for that threat. Now, to ensure that the nation is prepared for those future threats and existing threats that we are aware of, the ASPR has a product development division, and that is BARDA. Next slide. BARDA's responsibility is to support the development of medical countermeasures that address multiple threats: chemical, biological, radiological, and nuclear threats, pandemic influenza, and emerging infectious diseases. Now, we do this by entering into public-private partnerships with biotech companies and pharmaceutical companies, supporting their product development efforts. Now, our goal in doing this is to move those products from preclinical development, work that's gone on at the NIH and NIAID, and move those programs through clinical development, hopefully to FDA approval. Now, we're able to do that through the non-dilutive funding that we provide, the subject matter expertise that we have, as well as several flexible authorities. Next slide. In addition to product development, we are also responsible for procuring some of these products that have strategic value to the nation during a public health emergency. We do this using Project BioShield. This particular fund enables us to support the advanced research and development of these candidates and then hopefully procure them for stockpiling needs. Next slide. Now, there's several stages to a Project BioShield project, and it really starts with requirement setting. Ultimately, we need to have a material threat determination in hand for a particular threat in order to be able to procure that product. In addition to that material threat assessment, we also need to have requirements around the quantity of material that we are going to purchase, as well as a product-specific requirement, which outlines the actual key attributes of the products that we need to procure. Once we have all that information in hand, we can go out and solicit proposals, award a contract, and initiate our development effort. Within the antibacterial space, this really is late-stage phase 3 clinical development activities, non-clinical activities to support the development of that product and licensure of that product. Taking a step back looking at those MTDs again, within the antibacterial space, we have 5 MTDs that we respond to. This includes anthrax, drug-resistant anthrax, plague, tularemia, Burkholderia pseudomallei, Burkholderia mallei, and tularemia. We don't have an MTD for AMR. Once we've begun that development effort, along the way as we generate additional data, we really focus in on filing a pre-EUA. This enables us to begin regulatory discussions around the development of that product. Once there is an emergency, we would file an EUA. Next step, of course, is developing a stockpiling and distribution plans. This, of course, is a key component of Project BioShield, really enabling us to ultimately distribute that product, procure that product. and finally that procurement element, and hopefully FDA approval. Next slide. Now, there's several key considerations under Project BioShield. I've already highlighted the MTD aspect. If we don't have an MTD, we can also rely upon, or potentially rely upon, congressional appropriations during a public health emergency. We've heard yesterday about the fact that with additional funding, anything is possible. That is definitely true during a public health emergency. Congressionally appropriated funds would be specifically tagged for the development of a medical countermeasure for a specific threat. The other approach is a policy approach, and that is to develop an MTD during that public health emergency, which was done during COVID. Now, finally, the other point to make is that we cannot use a product off-label. Once we stockpile it, we need to have a way to use that product under a regulatory filing. This ultimately also enables that product to be distributed across state lines. Next slide. Now, there are two ways that we can stockpile a product. One is a more traditional route where the government buys and holds that product. The challenge here, of course, is that that product ultimately is going to expire, which means it will need to be replaced every so years. This could be quite costly to the US government. The second approach is called vendor-managed inventory. Under this approach, the sponsor or vendor holds that particular product at their facility. As that product reaches its expiry, it can be released into the commercial supply chain and sold by the company. But as it is released, new product enters into the vendor-managed inventory for the US government. This enables us to avoid that high turnover and loss of product due to expiry. Next slide. During a public health emergency, there are several stages that occur to release product from the stockpile. Clearly, the identification of an outbreak or an event is critical, as we talked about yesterday with diagnostics. Once that's occurred, we know that there is an event going on. Governors and state officials can reach out to the ASPR and CDC Operations Center, requesting material be released from the stockpile. That request is reviewed, and ultimately material then is packaged up and delivered to the sites that need it the most. And again, at the final stage there is treating patients and recovering from that event. Next slide. Clearly, all along the way, you can see that partnership is critical in our ability to respond to a public health emergency. Not only partnership across government agencies and partnership across state and local governments, but also with industry. This enables us to be more effective at what we do, have the necessary products on hand to accomplish our mission, and ultimately recover from these emergencies. And I thank you again and look forward to questions.
Thank you, Dr. Albrecht. You certainly brought up many points we'll be discussing during our discussion period. Next, we have Dr. Michael Ruff.
Good morning. It's a pleasure to be here. And as you can imagine, prevention of disease is something extremely important, not only for clinical reasons, but for this group relative to AMR. And so it's been a privilege to attend and present today. Next slide. So for this base scenario, I'd like to discuss applications and tools that are available for animal health through the USDA vaccine process. Within this scenario, swine influenza is a zoonotic disease. It is routinely diagnosed and detected, of course, in swine, but also canine, equine, and there are many documented cases in which animal workers and swine transmit virus back and forth. On the secondary infections and the bacterial, within this scenario, strep suis and G. parasuis are extremely pathogenic, oftentimes leading to high mortality, which is visually apparent and obviously emotional in the field, whereas the Pasteurella and the Bronchosectica tend to be more of a clinical and economic disease, respiratory disease. Besides for the clinical aspects, veterinarians in the field today also face severe issues of animal welfare, and they also have challenges of applying tools in the face of very limited labor. Next slide. I'd like to step back real quickly and do just a brief overview of the USDA process that regulates vaccines. Vaccines are regulated through APHIS, specifically the Center for Veterinary Biologics in Ames, Iowa. The regulations are encoded in the 9 CFR and are available for public review. And for a full license, there are several bullet points that are sort of the standard core tenets of how they assess a vaccine. First of all vaccines must be derived from a master seed, a single source isolate that is approved by CVB and is the basis for all routine serial production. Next, of course, we have safety and efficacy. Within the CVB assessments, safety and efficacy is typically done within the host species of origin. So in this case, swine vaccines would be developed in swine. Finally, for release, all products are tested for purity and potency before they enter the market. And so CVB puts a high level of emphasis on the very beginning of the process, the master seed, as well as the end, the release in the middle. And so it's a very defined and standardized process that's been replicated and studied across the world. In my experience in the commercial side, a typical, and this would be a very generic statement, but a typical vaccine cycle would look something like this. For a standard killed or inactivated vaccine, this would be a monovalent product. Those can typically be developed in the 2 to 3 year time frame. A non-GMO attenuated vaccine oftentimes can be developed in a 2 to 4 year time frame, and a GMO that requires going through the Federal Register process is a little bit longer, generally 3 to 5 years. There are 4 types of products that are available to our veterinarians today, and they each have different attributes and benefits. A vast majority are the fully licensed product. These are products that have checked every box, full dossiers, full testing, and are the products that our veterinarians use day in and day out. There is a CVB opportunity to produce a conditionally licensed product, and CVB uses the terms emergency, local situation, or special circumstance, and CVB themselves determine whether those criteria are met. In those cases, the emphasis remains on safety, but there are some lower levels of efficacy requirements, typically, and they use the word reasonable efficacy. So instead of doing a clinical challenge study and showing efficacy, you may be able to demonstrate serology as a surrogate. Using this conditional process, a license can be obtained quicker, sometimes in the 12 to 18 month time period. But it is not something they routinely do by any means, but certainly has been done in emergency situations. The third type of vaccine available is called autogenous, and these are routinely used on a daily basis by veterinarians. The key thing of an autogenous vaccine is by code, they have to be farm specific. So clinical material or isolates from a farm are sent to a diagnostic lab. Those isolates are provided back to a manufacturer, and a farm-specific, isolate-specific vaccine can be manufactured. These do take typically 8 to 12 weeks to manufacture, and there are no claims of potency or efficacy, and so the veterinarian and the farmer uses these at risk. The final classification, which is relatively new to the animal health industry, is called prescription. And so prescription is CVB's proactive approach to recognize that molecular tools and technology has changed, and we now have standardized vector systems that can be used to introduce new genes of interest in a more rapid way. And so they wouldn't use this term, but I would call it a molecular autogenous. So if you have a fully licensed product, and I'll use baculovirus as an example, based on baculovirus, you can go through the process to get a prescription license, which allows you to switch the gene of interest into your baculovirus vector. There are a couple caveats to that are important to recognize. First of all, there must be a veterinary client relationship in order to participate in the prescription process. So you literally have to have a veterinary prescription. And secondly, the vector itself must be non-replicating or inactivated. So this does not allow replicating products. And so, that has implications relative to safety and efficacy. Next slide, please. So within the veterinary animal health area, we are extremely lucky and blessed on the vaccine development side to have a strong panel of diagnosticians and available partners. And as Roger Main and Daniel Linares talked about yesterday, we have NBSL, we have a state laboratory group that is collaborative and oftentimes reports and harmonizes data under CHIC. And we are able to almost real-time track and report pathogens and the epidemiological patterns of those, which give us the opportunity to make rational and good vaccine selections and vaccine targets. Next slide. So specifically within your scenario of the pandemic, relative to influenza, if we had an influenza outbreak today, we would have licensed products available that could be used and applied within swine. This would certainly be the fastest option. Industries would have large stockpiles, vaccine distribution would have stockpiles, and veterinary clinics would have some level of stockpile. And so these products could immediately be applied. There's a variety of vendors. The isolates that are in vary from 1 or 2 per vaccine up to 4 and 5. They are all inactivated products. But as you can imagine with flu, sometimes having the correct clade matching is very important. And so these products may have some benefit, but may not be certainly the holy grail. Another opportunity in this response or this scenario, of course, would be to do a conditionally licensed product, which is a likely opportunity, but this would take 12 to 18 months to complete. Next slide. Within, again, the influenza part of this scenario, autogenous vaccines for influenza are likely the largest tool used today because veterinarians have found and believe that matched sequences and matched isolates are important in immunization. And I suspect in your scenario, autogenous would continue to be a very important tool, as well as the prescription product. There are 4 companies that have licenses for prescription. There are 2 that are commercially active. Both of them have vector systems that could swap out and include genes of interest for the HA and have an updated isolate. So within the flu part of your pandemic, I think the veterinary area would be well able to respond. Next slide. On the bacterial side, it's a much different story. There are very few licensed products. These products are extremely old. To be candid, they're relatively crude, grow it and kill it and fill it. And they would all have very limited efficacy. Within the scenario that you have, autogenous is the primary tool that veterinarians use. And the reason they can use that is that within the autogenous platform, they can create combinations. So they can do what they call a suicide combination, parasuis, strepsuis, et cetera, and try to broaden their protection. One of the challenges we have in the field and the reason antibiotic pressure is so high is veterinarians can introduce a broad spectrum antibiotic against the gram-negative very cheaply and easily, and they can do that immediately, not waiting 12 to 18 weeks for an autogenous. Next slide. Within this response, porcine respiratory disease complex would be a major challenge beyond the bacteria listed in your scenario. However, there are good tools available. I should note that despite the fact that autogenous vaccines are available, readily available, their benefit, is modest at best. Certainly, they are not magic bullets. They are one tool in a toolbox that would require biosecurity diagnostics and many other things. And so they are a tool, but certainly there would be significant pressure to continue to use antibiotics. Next slide. So in talking to a couple members of the PACCARB panel, they asked me to respond what would be some potential ways to respond and increase or improve our ability to respond. And these were just my opinions, and so open for debate and discussion. But certainly within CVB, currently companies provide the priority of which they want their information reviewed. Certainly CVB could make a conscious decision to put pandemic-related activities as a priority, which would speed up their response in commercial time. CVB could choose to either remove and change policy or not enforce the farm-specific part of autogenous. If you've got 3 farms all next to each other, they very likely have the same strain of strep suis or whatever bacteria you want. Having to wait 18 weeks for each of those, from a regulatory point, makes sense, but from a practical view, if you're trying to move quickly, being able to use autogenous vaccines across farms would certainly be helpful. Similarly, on the prescription process, that does require a veterinary client privilege. In a pandemic with influenza, the HA and the clade that spread across the country would likely be the same. And again, if that policy was changed, not enforced, that would allow us to move quicker. The prescription process itself is limited to the fully licensed species. So if the prescription is based on a swine vaccine, you can't use the prescription in cattle. We could waive that, or that policy could be changed, which would give us greater flexibility to respond. And then finally, a note that at the present time, we really don't have a bacterial vector system licensed and approved. So the systems we have are an alpha virus and a baculovirus, which are both very nice tools for viral antigens, but we do not have a strong prescription tool to represent bacterial pathogens. Next slide. So in conclusion, I think what we've done and what this group has also supported is the One Health initiative has been an extremely powerful tool and a well-designed way to address this problem. We have shared databases within flus, especially, but that could be broadened to other pathogens. We don't typically, but we could, in a real emergency, use FDA-approved tools in animal health, such as antivirals. That would certainly need to be subsidized. As Daniel Linares mentioned yesterday, because of the diagnostic tools we have in the epidemiology mapping, we would also have the ability to do test and removal if we choose, as well as regional control programs. So within the animal health, in summary, we have 4 different vaccine tools that can be applied. They each have strengths and weaknesses in terms of safety and efficacy and data packages, as well as their time to respond. Vaccines remain an important tool, but they certainly are not a magic bullet and must be used in context of biosecurity, diagnostics, and a One Health approach. And with that, thank you.
Thank you, Dr. Ruff. That was extraordinarily helpful. Thank you. We'll be talking again, I'm sure, during the discussion period. Dr. Emily Spivak.
Hi, good morning, everyone. I'm Emily Spivak. I'm the Medical Director of Antimicrobial Stewardship for all of University of Utah Health and the Veterans Affairs Hospital in Salt Lake City. I'm really honored to be here today. I was asked to basically say, what would you do as an antibiotic stewardship to this scenario that is presented? So I'm going to give you a very boots on the ground perspective of how the scenario that I was presented would impact human antibiotic stewardship and essentially how I would respond. Next slide, please. So when I first read the scenario, I just pulled out pieces that were notable to me from an antimicrobial stewardship perspective and listed them here. First and foremost, the frequent rate of bacterial superinfection on initial presentation to hospitals or during hospitalizations is, of course, notable. It was noted, of course, that many of these secondary bacterial infections are due to antibiotic-resistant pathogens, as you can see here. But I also noted that there are typical bacterial community-acquired pneumonia pathogens also causing disease, specifically penicillin-susceptible Streptococcus pneumoniae, Legionella, Mycoplasma. And I point that out because that impacts how we think about and guide people to use antibiotics for these secondary infections, especially in the setting of strained supplies, as was noted. And the scenario also noted a high rate of empiric use of broad-spectrum agents, listed here again because of the, I presume, high rate of antibiotic-resistant infections. But that leads to strained supplies, which would all these things would impact essentially how we would respond. Next slide. Before COVID, I honestly would have been at a loss as to tell you how antibiotic stewardship would be involved in a pandemic response. Now I have very strong opinions. So in the blue here is essentially in the middle in antibiotic stewardship program and around it, and I've surely left people out, but a sense of all the different groups within our health system and within our state, notably on the left, public health partners that we interact with really on a day-to-day basis. I overlaid this with 3 of the 4, but infection prevention and control is really central to what we do in stewardship. But the modules that you all are talking about with pandemic preparedness to show you that essentially within health systems and within human healthcare delivery, we are already interacting day-to-day with all of the different key stakeholders and players in these various parts of the pandemic response. And after COVID-19, I really view ourselves in conjunction with our infection prevention and control colleagues as central coordinators in a human healthcare delivery pandemic response. Next slide. So I'm just going to walk through some of the things that I would do specifically with these stakeholders within our health system. Our lab, specifically, of course, our microbiology lab would be a key stakeholder that we would be in intimate conversations with, and we would need to develop, guidance for our providers on viral and bacterial testing guidance. Essentially, who's getting tested based on different maybe clinical characteristics. Are we doing pre-op screening again? What are we testing them with? What are the new diagnostics or available diagnostics? And this will change, I presume, throughout this pandemic. When are we testing them again? Are we talking outpatient? Are we talking inpatient, emergency room, pre-op, et cetera? And where is sort of the same as the when. We would also be working with our microbiology colleagues to talk about antibiotic susceptibility testing for these resistant pathogens. Many hospitals don't upfront do expanded antibiotic susceptibility testing, but that may be something that I would think about to not introduce delays in knowing what the optimal treatment is, and maybe get expanded susceptibility testing going upfront, again, depending on supply chain. The supply chain, I would presume, as it was with COVID, is going to become an issue. And for stewardship, that's we become a potential catchment for that. So in COVID, our team, we had very limited rapid COVID testing up front. And we employed diagnostic stewardship mechanisms where our stewardship team had to approve. Essentially, we were kind of the gatekeepers for who could use a rapid test and when is the appropriate clinical scenario to do that. Then, of course, you can go on to the next slide. We would need to make sure and work with our lab and informatics colleagues that all of this testing information and antibiotic susceptibility information was incorporated into different surveillance reports that we have. On the bottom right there, this is just a screenshot of some surveillance reports that we have in EPIC, specifically for influenza already in existence and for some antimicrobial resistant pathogens. We would, of course, need to update those and expand those. And then you need to work with your lab colleagues to make sure that any new test codes or any new data streams are incorporated and added to those reports, and would need to clean those up as well. And we share this with infection prevention. And so, again, in collaboration with that group. On the bottom left are some Tableau views of NHS and AU data that we have and report to CDC, but that we grab and visualize in a really rapid fashion and more accessible on our side. And we already have the data architecture and we could do this next week if we wanted to, but to essentially integrate that antibiotic use data and link it with some lab data. Things that came to mind for me specifically were MRSA nasal PCRs for patients with pneumonia or influenza testing, so that in real time we can get a better sense of patients affected by this pandemic and what the antibiotic use patterns are on various units, would be as granular as we could get it, to try and, again, target our efforts, because we're going to have limited resources of where we should be acting and trying to improve antibiotic use. We would also need to work with our informatics colleagues to change all of our order sets in our guidelines and our antibiotic ordering processes. In a minute, I'm going to talk about if the national supply of antimicrobials is strained, and even, I presume this is even fully FDA, been using them for decades, antibiotics. I would employ very rapidly antibiotic restrictions across my health system, so that we can streamline and appropriately target where those drugs are used, and that requires some informatics updating as well. And then lastly, COVID has taught us a lot about outpatients during a pandemic. And how you need to think about that, and honestly probably think about it first. And we would talk with our informatics colleagues about also identifying outpatients who test within our system who are influenza positive, and possibly think about outreach, or are there possible therapeutics coming through the pipeline or existing that we would start to proactively outreach, whether it's through electronic means or manual means, to these patients to try and treat them ahead of time to prevent hospitalization and hospital strain. Next slide. Infection prevention, I'm not going to go through too much detail because most of the things I'm talking about, we would do in intricate collaboration day to day with these colleagues, again, focusing on our diagnostic pathways for influenza and these antimicrobial resistant agents. Again, all of the informatics and data streams are shared and would need to be developed in collaboration. And when the dust settled, we would also need to communicate and look at any changes in typical pre-pandemic hospital-acquired infections and any role that antibiotic use that we had to turn our eyes away from may have played in increasing hospital-acquired infections. Our pharmacy colleagues, again, an intricate part of our stewardship program, specifically at University of Utah, we have an amazing drug information service that many national partners also use that would have to keep us up to date on supply chain issues, shortage issues, and any FDA changes as far as, are there new therapeutics, are they under an expanded access IND or EUA, and that would be the partners that would keep us up to date and communicate with us on those processes. And internally within University of Utah Health, it's our pharmacy team, of course, who helps us with the policies and the processes involved in putting any kind of drug under a restricted ordering status, and messaging that across the health system. And I mean, we're the team that does that. So now we can do it with labs, diagnostics, drugs, and we would do that very, very rapidly, I would presume, in this situation. Next slide. I put this outpatient stewardship piece last, but I probably should have put it first. One thing I hope we learned from COVID and thinking to NIH is we need outpatient clinical trial networks to really, in a respiratory pandemic, hopefully study therapeutics earlier in the course of disease. It is very evident, at least in my opinion, from COVID, our inpatient therapies have very minimal impact on disease and on outcomes. However, specifically pre-Omicron, the outpatient COVID therapies were quite impactful and really did save hospitalizations and saved lives. Unfortunately, we didn't get to them until the end of the pandemic. And for Paxlovid, really when it was too late for much impact of that drug. So I would hope that we would think about developing therapeutics in a flipped model from how we did for COVID-19. And then once those therapies are developed and are available, stewardship programs have to think about, we catch them, we receive them, and what are we going to do and how are we going to disseminate these drugs, and developing guidance around how to prescribe them and how to identify patients, which is much harder when they're not within the four walls of your hospital. How do we identify patients who could benefit from these therapies and get the therapy to them, and do it in an equitable fashion so that those with poor social determinants of health or those who can't advocate for themselves or don't have people to advocate for them also have equitable access to these therapies. So we would be thinking about all these pieces on this slide ahead of time. And if COVID had not happened, these things would not be on my radar at all. Next slide. My team specifically day to day, what are some of the actions that we would do? I've said a lot of these things, but we would very rapidly, and it would, I'm sure, evolve over multiple iterations. I think we have 25 versions of our COVID guideline, but we would develop and update our influenza and bacterial superinfection guidelines, specifically community-acquired pneumonia, and we have a separate multi-drug resistant gram-negative guidance document that would need updating based on supply chain restrictions, potentially new agents that are available. Like I said, we would restrict, and then what that would mean is that we were the gatekeepers for many of the broad spectrum antibiotic agents that are currently widely available at our institution. We would take control over those due to supply chain issues and excessive inappropriate use that I would anticipate. We, of course, have a pager where we manage all of these calls for restricted drugs and diagnostics and other questions. We would likely implement daily rounds with our intensive care unit, or at least several times a week with our intensive care units that are housing these patients, to, again, just in real time go through and provide guidance on how to change therapy and what are the optimal therapies for them, and maybe even advise on play a clinical trial role as we did during COVID as well, and enroll patients in clinical trials. We would do the same for our influenza patients on other floors, and this would all require, again, those informatics inputs for us to identify where all of these people are day to day and run reports on our positive flu cases. And then we provide regular updates in our communication tool for our health systems and also for our communities. So I gave regular updates weekly to our hospital staff. And stewardship programs naturally take on this because they are up to date on the epidemiology in partnership with infection control and treatment. And we tend to be decent communicators. And so we give regular updates to our health system and then are tapped by our media relations and print and radio and TV to also be engaging our community and keeping our community up to date, which is another role we would take. Next slide. And then our public health partners. Again, I didn't know this or think about this before COVID, but I would presume based on this scenario that we would anticipate what I might call a federal restriction or allocation of maybe even existing fully long-term FDA-approved agents or novel therapeutics coming down the pipeline. I would presume, again, that would be coordinated through people, partners at the table here through our state health departments. But I would like people to recognize that many state and local health departments do not have expertise within those agencies to know how to treat these patients, how to interpret this data, and how to think about who are the appropriate populations medically really to receive these therapies. And so we need to think about, are these therapies going to be on the inpatient side, on the outpatient side? There's very different delivery models, and how are we going to guide health departments on how to distribute these therapies in a clinically meaningful way, but also promoting health equity. Next slide. In Utah, I'd like to think that we did this fairly well for COVID-19. We developed a scarce medications subcommittee of our state crisis standards of care with all the major health systems and partners in the state at the table, and as well as an ethicist, pharmacy representation, and our State Department of Health, of course. We formed around the time remdesivir was EUA approved, developed how we were going to allocate it, the sort of algorithms for that, and also clinical criteria for use. And we did the same with all of our outpatient COVID therapies as well, used internal state data to better understand what are risk factors within our state for poor outcomes from COVID. And we also used this group to really promote equity and make sure that we were delivering drug equitably across rural settings, again, other disenfranchised communities, and make sure that everybody was sticking to the same, the way that we all agreed that we were going to prescribe the drugs. Unfortunately, our legislature has now tied our hands on this, and this group can no longer exist or function without approval of multiple high-level state leaders. But something to think about, I think, policy-wise. And I would just make a plug that states need guidance on how to distribute these drugs. A lot of states, I heard, it was people just grabbing for what they could, which I think promotes health inequity. Next slide. So how are we going to do all of this with our stewardship team? So on the left, you can see a snapshot of current state, sort of what the breadth of our health system is. We have one physician, it's 0.7 of me and 0.3 of another physician and 2.5 pharmacists who cover all of that. On the right are really the sort of day-to-day, on the ground, pre-pandemic or non-pandemic stewardship actions that CDC recommends, or in the CDC core elements. And I put the strike-throughs there to let you all know that we would essentially stop doing all of the day-to-day stewardship activities that are part of the CDC core elements because we would have to turn and focus on the pandemic. There's a few things there that I think are high priorities that we would try to maintain. Many stewardship programs did just what I'm talking about here for COVID. Some were shut down completely because employees were furloughed or had to be redeployed to other activities. So I just want to make the point that stewardship, we would have to shift away from typical sort of, stewardship activities to focus simply on this pandemic response. Next slide. And hopefully I'm making the case that I really strongly believe that expanding stewardship staffing is imperative to pandemic preparedness. And again, before COVID-19, I would not really have understood this or had as much of an appreciation. Stewardship is required, as we all know, through CMS standards across healthcare. CMS does require that you dedicate human, financial, and information technology resources, but there are no staffing models or no sort of formal staffing standards that exist. On that bottom right, that graph is several studies that have been published over the years or from around the world through time and motion studies or surveys looking at what are the appropriate staffing sort of benchmarks for stewardship. Pre-pandemic, it was recommended one person or one FTE per 250 beds. Many of us are not there now, and that is based on work that was pre-pandemic, not on all the new roles that we have taken on. Next slide. So in conclusion, we've learned from COVID-19 that antibiotic stewardship or antimicrobial stewardship programs touch multiple aspects, and I'd say almost all, at least in human healthcare delivery aspects of the pandemic response, and play a really pivotal role in coordination and communication across those groups. Due to resource limitations that existed pre-pandemic and stewardship programs, stewardship program activities are going to suffer the day-to-day that is recommended by CDC because we're going to have to pivot. And investing in stewardship resources, I think, is really key to fighting not only the silent day-to-day AMR pandemic that is ongoing, that is clearly going to be unroofed, and this scenario is a good example of that, but also, the viral pathogens that are going to emerge. We barely have enough people on the field for a routine game, but, in this national championship, we would just get creamed because we do not have enough resources to respond appropriately. Thank you.
Thank you, Dr. Spivak. Thank you for sharing these really well thought out ideas. Dr. Gail Golab.
Good morning, everyone. Can you hear me okay?
Can you move the microphone just a tad closer?
It says it's not. Thank you. AVMA very much appreciates the opportunity to speak with you all here today and talk a little bit about the role of associations in pandemics. One of the things that I wanted to do, if I could have the next slide, please, is to first talk a little bit about the range of associations we're talking about. I want to make sure that we don't forget about all of them. AVMA is certainly one type of association, but there are numerous others. So the American Society of Association Executives, which is essentially the Association of Associations, defines an association as an organization or group of individuals affiliated with one another who share a common purpose, interest, or mission and exist for the mutual enrichment and advancement of their membership. And of course, there are many types of associations, but the three most common are trade associations, which are established by individual industries for the sole purpose of allowing businesses in the same industry to connect to and benefit from one another. The National Pork Producers Council, for example, is one of those trade associations. Professional associations, on the other hand, are organizations that are established to further specific professions and the interests of those who work within them. Unlike trade associations, the membership of the professional associations are individual members within the profession who share a common belief or purpose. And so the American Medical Association, just like the AVMA, would be an example of a professional association. And then we have philanthropic organizations, which are groups that give or receive support from money allocated for humanitarian purposes. The American Lung Association is, of course, an example of a philanthropic organization. And of course, many organizations qualify as non-governmental organizations, which are organizations that are neither part of a government nor part of a conventional for-profit business. NGOs can be funded by governments, foundations, or businesses, and are highly diverse groups of organizations engaged in a very wide range of activities. And NGOs can take very different forms in different parts of the world. Some may have charitable status, while others can be registered for tax exemption based on recognition of their social purposes. And all of these types of associations can play critical roles during pandemic events, and that's something that AVMA learned very quickly. Next slide, please. So similar to its counterpart in human medicine, the American Veterinary Medical Association is a professional association serving the veterinary profession and, by extension, veterinary patients and clients. And we anticipate that the membership of the AVMA is going to comprise more than 100,000 veterinarians by the end of this year. And what's really unique about the AVMA is that we have about 75% of veterinarians that are members of the association. That is very unusual. For most professional associations, we're looking at 20 to 30%. So what that means is that we have a great deal of reach within the profession, and we also have a great deal of trust and authority within the profession. So AVMA is a member-focused and a highly respected and trusted association, and our activities are directed by more than 400 volunteer members of leadership. And that volunteer leadership is supported by about 170 staff members, and about 25% of those staff members are veterinarians. And among that volunteer leadership and staff leadership, many of these veterinarians have advanced degrees in addition to the DVM and also carry specialty board certifications, so the extent of expertise is tremendous. I want to make sure I mention the American Veterinary Medical Foundation, which is a charitable arm of the AVMA. That foundation focuses on support of veterinary education, veterinary research, charitable care for animals, and disaster response. In addition, the AVMA Professional Liability Insurance Trust and the AVMA Life Trust provide professional and personal insurance products that are available for AVMA members. Next slide, please. While AVMA comprises individual members, we reach across the profession and we work collaboratively with a variety of other professional organizations and their members, including our species and practice type Allied Veterinary Association. And so, for example, those would be representing companion animals, equine, food animal, zoo and wildlife, public health, and federal veterinarians. We also work with state veterinary medical associations in every state and territory of the United States. We work with 22 different veterinary specialty organizations that represent 46 distinct specialty areas through the American Veterinary Medical Association supported American Board of Veterinary Specialties. And we also work with the veterinary medical regulatory boards in all 50 states and in territories. And so our interactions with these various groups are constant and they're consistent. And one of the reasons for that is that most are directly integrated into AVMA's operational structure. So AVMA's interactions within the veterinary space also extend beyond veterinarians into associations representing veterinary practice team, including veterinary technicians and assistants, veterinary office managers, and customer and service representatives. Next slide, please. So this is a busy slide. And of course, AVMA's communication and collaborative activities are not limited to those with other associations. We also have relationships with members of Congress and staff across the federal agencies, and we work with a variety of academic institutions, those that are both education and those that are research focused. And if we move across the spectrum on this slide, within the animal health space, we maintain connections with federal and state veterinary diagnostic laboratories, with a variety of businesses involved in animal agriculture, pharmaceutical and medical device manufacturing and distribution, and biomedical research. We have connections with state veterinarians and public health veterinarians, and with the federal and state emergency management and disaster response agencies. And if we move outside the animal health realm, we regularly interact with the other professions, so medicine, dentistry, pharmacy, and law, on issues that are of mutual interest. We also, however, provide information for the public, either through material that is distributed by our members and by our practices, but also directly through AVMA's website, through public service communications, and through traditional and social media. And of course, like most associations and businesses, the AVMA reaches globally through its relationships with groups like the World Veterinary Association, World Organization for Animal Health, and the World Health Organization, as well as regional relationships with groups like the Federation of Veterinarians of Europe and the Federation of Asian Veterinary Associations. So what this means is that AVMA is able to serve as a really valuable central hub for the animal health space in emergencies. We have the reach and we have the relationships to both tap indispensable expertise and get resulting information and materials distributed efficiently and effectively among animal health providers and businesses, to regulators, and to clients and the general public. Next slide, please. Unfortunately, and as we've spent a lot of time discussing over the past couple of days, one such pandemic emergency played out recently, COVID-19. And we had an opportunity to really see the power of associations, including the AVMA in action. So the actions we took during COVID-19 bear an uncanny resemblance to what would be needed in a response to the hypothetical scenario we have been discussing here. And so as COVID-19 hit, AVMA moved very quickly to identify key contacts in critical organizations, agencies, and institutions. And we scheduled regular calls with those individuals to ensure that our response to the pandemic was appropriately targeted, was practical, and was timely. And so quality guidance for veterinary teams and practices in treating patients and in protecting staff and clients from unnecessary exposure was absolutely critical. Unfortunately, AVMA routinely and proactively creates and/or we distribute guidance in key areas involved in public health and animal health emergencies, such as biosecurity, antimicrobial stewardship, and animal population management. We also recognize, however, that emergencies present examples of where guidance may need to be quickly adapted or where it may not exist. So during COVID-19, we actually had the opportunity to address both of these situations. We developed additional materials to help veterinarians and their teams directly and easily apply existing guidance. And we also quickly identified alternative approaches and worked with expert parties to develop new approaches when necessary. So, for example, in response to supply chain challenges affecting various pharmaceuticals, PPE, and animal populations, as well as personnel shortages. We also worked to mobilize personnel and equipment. Emergency management functions were supported by veterinary volunteers, and we collaborated to locate sources of needed supplies and help direct those to human health care, while identifying at the same time alternatives for veterinary practices so that we could take care of our own patients. Examples there included PPE as well as ventilators. We also worked with diagnostic laboratories and state and federal agencies to obtain authorization for those laboratories to perform testing of human samples for SARS-CoV-2, filling a critical need that otherwise would not have been met. And with a limited budget, we were grateful that the American Veterinary Medical Foundation and the AVMA Trust were able to provide some financial assistance for these activities. And so the value of philanthropic and business organizations as sources of funding during emergencies shouldn't be overlooked. Next slide, please. Of course, good communication during a public health emergency is absolutely critical, and associations can be incredibly helpful in making that happen. Again, using COVID-19 as an example, the AVMA created a web center that included comprehensive information needed by veterinarians, their teams, other stakeholders, and the public. We shared information about the virus itself, including its human and animal impacts, provided practical guidance for veterinary practice operations to minimize and manage exposure of both people and animals, provided updates on vaccine availability, information about small business relief programs, and provided well-being resources for a population of care providers that were incredibly stressed. Our resources reflected contributions from across the profession, the animal health industry, public health, and government, and they evolved in real time. We also offered regular continuing education sessions via our digital education program, AVMA Axon. We recognized early on that the value of guidance was limited unless it was also accompanied by training. We raised awareness about our web center and drew attention to updated information through multiple communication vehicles, including all member emails and e-newsletters, listservs, the AVMA journals, media releases, and social media. The quality and timeliness of AVMA information was actually recognized nationally and globally, and ultimately we won multiple awards from the American Association of Association Executives, the World Veterinary Medical Association, and several public relations associations. Next slide, please. Finally, I want to talk about associations and advocacy. And so the importance of advocacy during a pandemic can't be overstated. Just like people, associations develop relationships, credibility, and trust over time. These kinds of relationships are critical during a crisis when there is a massive and urgent need for information and support from multiple places. including Congress and state legislatures, federal and state agencies, and a variety of industries, businesses, and their associations, all of whom absolutely have to work together successfully to deliver in a crisis. And advocacy led by associations can move mountains, and it did during COVID-19. Thanks to veterinary professional advocacy, veterinary practices were designated as essential services at the federal and state levels. This allowed us to protect animal and human health, as well as animal resources. The relationships that were built facilitated recognition of the need for clear guidance and a desire for a collaborative approach in developing that guidance. The latter avoided impractical or unimplementable recommendations. Association advocacy also played a critical role in appropriations for response and release efforts and allowed recognition of training and skills that led to a cadre of boots-on-the-ground veterinary vaccinators and support personnel who could help traditional human healthcare providers deliver life-saving vaccines in the midst of staffing shortfalls. So this was a really quick overview of some of the roles an association like the AVMA, but certainly not limited to the AVMA, can play during animal and public health emergencies. Thank you.
Produced by the U.S. Department of Health and Human Services.